The Eastern Cape Department of Health has ramped up efforts to address a dual crisis, a surge in child and teenage pregnancies and the subsequent vulnerability of newborn infants. With the province recording some of the highest adolescent fertility rates in South Africa, nearly 18% of all deliveries, health officials are shifting from a purely clinical response to a community-integrated model. Let's unpack this with Eastern Cape Health MEC Ntandokazi Capa. MEC, appreciate your time. Thank you for speaking to us. Now, what's prompted this intervention now? What are you seeing in the Eastern Cape that made you say we need to move urgently?
Thank you very much, Hugo. A good day to you and the viewers. We have seen, as you said earlier, a rising numbers of teenage mothers in the province. If you remember, I think sometime in June, we recorded from March to June above 4,700 teenage mothers from the age of 15 to 19. That is a number that is not as acceptable for us as the province, especially for the two districts, which is OR Tambo, the leading one, and followed by Alfredo, and then followed by Buffalo City. So we are really trying our level best to intervene because we've seen the rise of the numbers as the province.
MEC, let's talk about your intervention. When you speak about trying hard to intervene, what exactly is it that you are doing in order to stem this problem?
One, we have established what we call youth zones in our clinics. Youth zones are areas that are dedicated for youth and also employ young nurses and young doctors so that they can be able to interact and relate with the teenagers. Because if they were to meet with me as an adult, they would also be scared that if I go in that clinic and meet with MEC Capa of her age, they is going to go back and tell my mother or my father that I went there to seek for any contraceptive or any form of reproductive health. So those are the areas that we are trying to intervene to, that we try to have facilities that are friendly, that are giving an environment that is conducive to our youth. Again, we have what is called integrated school health, where we partner with Department of Education and Social Development so that we try and take our services to where teenagers are, that is into schools. So those are one of our interventions that we have as the province. But I think what is key and what is important is for us and the community, especially parents, to take a leading role in addressing this issue of teenage pregnancy, because teenage pregnancy does not start at school. It doesn't start in our facility, but it starts at home. So we ought to, all of us, to find a solution and find an integrated approach.
MEC, let's be blunt. When girls aged 10 to 14 give birth, we're speaking about children, right? What is the standard protocol in your facilities when a child presents pregnant or in labor, and who gets notified and how quickly?
We quickly have to notify social development so that they take upon, because remember, children are a responsibility of a Department of Social Development. But remember, with the amendment of the Act, it does not necessarily solely depend on social development. As the department must also report, if you remember last year, on the 1st of this year, on the 1st of January, we had a 12-year-old that gave birth in our facilities. And fortunately, that is exactly what we did as the department, was to report to the police. Unfortunately, or fortunately, I don't know, the father was a 17-year-old. As a result, they had to wait for a certain period in order to prosecute. But as the department, we quickly reported. That is what is the protocol for us. And again, we've also issued a correspondence to all our facilities to say, if you encounter such an incident, quickly sensitize the head office so that we make a necessary follow-up as the department. That is the protocol that we follow as the Department of Health.
MEC, you've given us a single case, right, in which that particular individual was potentially hauled before the courts. At least, at the very least, police were on standby. Now, are you satisfied that cases are being reported, investigated and prosecuted? And what are the obstacles? I mean, there's fear, family pressure, evidence, community silence, maybe?
One of our obstacles, in some instances, you'll find that you are dealing with a child-headed family. That's another obstacle. And again, remember I said the responsibility of Department of Health is to take social development on board, so that social development will then pursue whatever that is supposed to be done. And I can assure you they really play their part. They send their social workers, they make a follow-up. Unfortunately, I would not have the stats in terms of convictions, because it certainly depends now on the social development. But our responsibility as Department of is to see to it that we report at the same time, we sensitize social development. For now, I can say I do not have the stats in terms of conviction, but I also saying the issues of stereotype and issues of myth does have a contribution to us as the department.
Let me see, that's one half of the story, right? Which is what happens prenatal, but there are obviously other issues postnatal. Now, in rural districts, distance and staffing are huge. What are you doing to reduce missed antenatal visits, late bookings, and dangerous delays in referrals?
To our pregnant mothers, if we are also having what is called Wabako teams that are visiting homes, so that we detect pregnancy early. Once we detect a pregnancy, we send it to our facility. We proceed with our antenatal care, as well as making sure that we pre-book you, so that we prevent any complications. For those high-risk pregnant mothers, we then refer them to a higher level of care. If you were in a district hospital, making an example, we'll send you into a teacher hospital, so that we try and prevent, because as the province, we are prone to litigations. That is why we are really trying our level best to pre-book our mothers. We've got a lodging areas where we pre-book them, so that we are able to monitor them. And again, we are also making sure that once we visit you in your home, we initiate you into the system. So our work backward teams are really working hard in visiting families. We are trying not to wait for them to come to our facilities, but to go them to where they are.
MEC, you would obviously have first-hand information for us on life post-birth. So once a mother has given birth, and we're talking about a teenage mother or very, very young mother, what is life like on average for this individual, for her, for the child? These young girls are obviously extremely vulnerable. How do you deal with that vulnerability? Are there means and ways of ensuring that this doesn't recur? Because obviously if these are child-headed households, and if it's a case of economics that is playing a part in the pregnancy, how do you ensure that it doesn't repeat itself in the same individual?
That is why we monitor. Remember, once they are mothers, they continuously come to our facilities, so that we immunize the babies. That's when we then introduce our services in terms of reproductive health. We also encouraging them to take what is called an implant on a long-term contraceptive options. And I can say most of them, they do take that option, let alone that in some instances, you will find that there are these beliefs that others believe that if you put a long-term contraceptives, you might not have to have children ever again. So those are the challenges that we're encountering. But once you are in our system, we're able to monitor you, we'll encourage, we do have social workers in our facilities so that they engage. Remember, I said we've got youth zones. That's where we have our talks with them to say, here we are, we understand that maybe it was a mistake, but we don't want it to be a repetitive mistake. Hence, we provide and we encourage them to take contraceptives. But again, we try our level best. Now here's a baby from an indigent family. That is why we are encouraging NGOs to partner with us to provide those postnatal kits for our mothers, so that at least in a situation where you already have a baby, that baby must not suffer because of circumstances, so that we provide such packages.
Fred, we've run short of time, MEC, but certainly would have liked to understand some of the challenges that exist in you explaining child control, if you will, to some of these 12 and 13-year-olds. There's the Eastern Cape Health MEC Ntandokazi Capa walking us through some of the challenges with young mothers and certainly the amount of work that they're doing to deal and assist in those situations.